Everybody, lovely to be here. Thank you very much for the invitation. As Claire said, I'm very much a GP at heart. I'm a partner at Woodlands Medical Centre, which is in Ely in Cardiff, but I have a special interest in diabetes. So I actually did hospital medicine before I jumped ship to primary care, and I very much carried on that interest that I gained there in the management of diabetes. And certainly in primary care, we hold a vital role in the holistic management for people living with type 2 diabetes. So as Claire said, I have a role both in Cardiff and Vale as the diabetes lead for primary care, but also on the Diabetes Strategic Network as well, which we'll hear more about from Sue after my presentation. So quite a broad sort of brush title this really. So I've included hopefully some useful snippets for, I suppose, that primary care approach and how things are looking currently in Wales. So I suppose we'd better start with the numbers, folks. Oh, look, I can't move the slide. There we are. Let's have a little look at the numbers. So we know that the majority of people living with diabetes are living with type 2 diabetes. About 90% of cases of diabetes are type 2, about 10% are type 1 diabetes. Very different conditions, of course. Type 1, autoimmune, lifelong requirement for insulin therapy. Type 2, much more complex in terms of the reasons why people develop type 2 diabetes, often close links with people living with overweight or obesity, people with genetic conditions that make them more susceptible to type 2 diabetes, and many, many, many other complex causes. What we know is that the numbers of people living with type 2 diabetes has been increasing over the last few decades. These are the numbers here in Wales. We can see that red line, that steady increase over time. And in fact, we've got just over 200,000 people now living with type 2 diabetes in Wales. This data is from Public Health Wales. And you can see those potential predictions going forwards. So almost 300,000 people potentially living with type 2 diabetes in Wales within the next decade, if things continue at that higher level of increase. Of course, what we want to do is try and flatten things off, and we'll hear more about things like the All Wales Diabetes Prevention Programme as we go through the morning. Now remember, the numbers we see here does not include people living with undiagnosed type 2 diabetes. Remember, type 2 diabetes asymptomatic initially, so people do not report symptoms, and it's only if we can identify those at-risk individuals, which is an important role we have in primary care, try and pick up people early on so that we can make sure that they have optimal control. What do I mean by optimal control? Now we know that type 2 diabetes is a disorder of high blood sugars, high glucose. We measure that on something called HbA1c, which looks at the average glucose in someone's bloodstream over about a 3-month period. The evidence strongly shows us that if we can help people to manage their blood glucose, to bring it down to a good level, preferably a normal level rather than a diabetes level, that reduces the chance of developing complications of type 2 diabetes down the line. What complications am I referring to? We can broadly divide the complications of type 2 diabetes into macrovascular and microvascular complications. So macrovascular, things like myocardial infarction or heart attack, stroke, peripheral vascular disease. Microvascular complications, things like retinopathy, potentially leading to sight loss, and painful diabetic neuropathy as well. What the evidence shows us, and you can see here, is that increasing glucose control, so lowering HbA1c, significantly reduces those complications in the future, therefore increasing the quality and quantity of the lives of people living with type 2 diabetes. Now, it can be very difficult to achieve those glucose levels. How do we go about it? Well, we know that type 2 diabetes, at the heart of type 2 diabetes, is education, self-management, engagement of the person living with type 2 diabetes. The way that we talk to people living with type 2 diabetes is very important. And there's been a big drive around the language that we use over the last few years. There was an excellent NHS England document published, about probably 6 years ago now, called Language Matters in Diabetes, and it's recently been updated. Perhaps in the past, we've had a tendency to use blame language to sort of make people feel it's their fault that they're living with type 2 diabetes. We now understand that is not the case. There are many, as I said, complex reasons as to why people live with overweight and obesity, why people develop type 2 diabetes. In primary care, we have a vital role in the holistic management of people with type 2 diabetes, potentially for many years. Developing that therapeutic relationship with people, people getting to know us as GPs, our practice nurses, our clinical pharmacists, is a vital part of that. So using good language, supportive language, empathetic language is very important. In terms of self-management, we know that engaging a person living with type 2 diabetes and enabling them to self-manage, to understand their type 2 diabetes and what changes they can make in their life is very important. And structured education is vital here. With various offerings across Wales, and I'm sure that Kath will tell us more, but the expert programme, for example, an educational programme for people living with type 2 diabetes, is a wonderful way of helping people to self-manage. But we know we need to increase our offerings. Attending a 6-week course, it's very difficult for some people. So we now have online offerings as well, such as My Desmond, that people can use online to get online education. We need to think about cultural and language barriers as well when we're helping to engage people around living with their condition. And remission of type 2 diabetes, getting rid of it through weight loss. Kath will tell us more. That is a realistic option for some people with the right resource and support. In primary care, and many of you, if you live with type 2 diabetes or know of people who do, you know the annual diabetes review, which takes place at least once a year in primary care, is a vital part of our role. This helps us to engage our person living with type 2 diabetes, see how they're getting on, have a look at things like their HbA1c, blood pressure, and so on. And part of that process is completing what we call the essential care processes of diabetes. These are the 9 8, there's either 8 or 9, I'll explain why in a moment, that's slightly complex. In primary care in Wales, we certainly focus on the 8 care processes. And these are things that everybody living with diabetes should have done at least once a year. Let's go through them. So measurement of HbA1c for glucose control, blood pressure, a serum cholesterol, so checking your cholesterol level, checking your creatinine, a blood test for your kidneys, checking your urine albumin creatinine ratio, another test for the kidneys, but using the urine this time, having your feet checked, having your body mass index recorded, and having your smoking status recorded as well. In Wales, we also, of course, have retinal screening. That's carried out by our eye screening Wales department. So it doesn't really come under primary care, but we have to make sure in primary care that people are referred to the eye screening process and that they're able to chase up if they've missed appointments or need new referrals. So if we can get all of these care processes done for everybody living with type 2 diabetes at least once a year, the evidence shows us that that improves our pickup rate of complications early on and increases our ability to get that glucose control that I talked about earlier. So how are we doing in Wales? Well, this shows the number of people in Wales with type 2 diabetes that have had all 8 of those care processes completed year on year, going back to 2018, and this is from the National Diabetes Audit. So what do you reckon happened with that big dip there? I think we can all guess, can't we? So you can see where COVID hit, and the number of people having all 8 of their care processes dipped right down as people were no longer able to come into the surgery. By the middle of 2023, which is the last yellow line here on this graph, you can see we were getting back up to baseline. But you see that actually the numbers are quite small. This is the number of people with type 2 diabetes, remember, with all 8 of those care processes completed. Only around the 40 to 50% mark of people getting all of those care processes done. So definitely we have a real drive to try and increase the number of people getting their care processes completed. If we look at which care process is which, and don't worry, I'll talk you through this. This is looking back from June 2022 until December 2023. That purple line at the bottom is everybody having all of their care processes done. So just over the 40% mark and pretty steady at the moment. Very difficult to get all of the care processes done. Often you're missing one or the other. If we look at the bottom 2, you can see the worst performed care processes are that lilac one there, which is the urine albumin creatinine ratio, that urine test we do for the kidneys, and the dark blue, foot check, so looking at people's feet. So we're not so good at getting those done. We're much better at getting the ones near the top done. That's having an HbA1c blood test, a creatinine blood test, recording BMI and smoking status. We're quite good at getting those done. Not so good at getting a foot check done and getting the urinary test done as well. So these are the ones we're really going to try and focus on over the next year or two, try and increase the reasons why we're not managing to get these done. And there's a real focus on that urine test, the least well performed essential care process. So why are we not very good at getting that urine albumin creatinine ratio, or ACR, done? Well, it is a very important test, but sometimes I think maybe we don't fully understand the need for this test. One big debate, I suppose, in Wales has been around QOF. Now, you may have not have heard of QOF. QOF stands for Quality Outcomes Frameworks. This was a system that was put into place in primary care, gosh, probably over a decade ago, which meant that primary care practices were rewarded for achieving various clinical targets. So, for example, in diabetes, you'd have to get 80% of your patients living with type 2 diabetes to have an HbA1c under a certain number. Or you'd have to get 90% of your patients living with type 2 diabetes making sure they had their urine test done. Now, we've moved on from QOF here in Wales. It's still in England, but we've moved on from QOF here in Wales, and we look more now at quality improvement rather than target setting. Now, like it or not, and then I think there's lots of advantages and disadvantages to things like the QOF system, but I do think that taking it away has probably led to, I suppose, not less of a focus, I suppose, on getting these tests done, because we've lost that tick box that we needed to get it completed. As I mentioned, also, I think there's a lack of awareness for people living with diabetes, but also for healthcare practitioners about the value of this test. There's an educational need here. That urine test may seem very simple to get done, but it's actually the canary in the coal mine that all is not well in your kidneys. It's that early warning sign that things are not going well. It's a tiny little bit of protein that's leaking into the urine, which shows early kidney damage. One of those complications of type 2 diabetes that I mentioned earlier on. Actually, I think a lot of people, certainly from my own anecdotal evidence gathering in my practice, and I'm talking about people living with diabetes and healthcare practitioners and non-clinical staff on the reception, think that that test is for sugar in the urine, but actually it's to check your kidney health. So a big educational drive around why we need to get that test done is important. And the evidence shows if you get that test done, you can put in interventions to help to protect kidneys and reduce the risk of someone needing dialysis in the future. There's also practical issues around which sample bottle is used, what time of day it's done. Ideally, that sample needs to be done first thing in the morning, but my new mantra, and you'll see it in bold there, any we will do. We'll take urine at any time of the day if we can make sure we get this test done to check people's kidneys. So a lot of work going on at the moment in primary care to draw the eye of primary care back to getting this test done, the importance of focusing on reducing the risk of kidney disease for people living with type 2 diabetes. The way that we look after people living with type 2 diabetes in primary care has changed massively over the last decade. The traditional approach of a person living with type 2 diabetes coming to see me, a GP in the practice, to talk about their diabetes once or twice or 3 times a year has really now moved on. We have so many different people involved in the care now of people living with type 2 diabetes, a true multidisciplinary team. A lot of care led, and you can see on the top right of my picture here, by our nursing team, often our practice nurses leading chronic disease management in primary care, probably overseen by a GP, but also lots more involvement by other multidisciplinary team members. Clinical pharmacists, very important now in driving care, social prescribers, mental health practitioners, that whole package with the person living with diabetes in the centre. And then when we need additional help, of course, we call to our dietitians, our podiatrists, and perhaps our diabetologists when required. So really, I think a change in that care model, and indeed the way that care is delivered to people living with diabetes, varies across our different health boards. In some areas, there's more focus on community teams. On some areas, there's more focus on secondary care management. It is quite variable, depending perhaps on the locality. And of course, the geography varies massively across Wales, which can affect the best care model for that particular area. So in terms of care models, in terms of the future planning for people living with diabetes and the way that care is delivered, a big focus in Wales, which I'm sure many of you will have heard of over recent years, is value-based healthcare. What does that actually mean, and how is it relevant for us? Well, we are facing a problem, folks. We know that across the world, the cost of care is rising at a significant and unsustainable pace for all healthcare systems. The NHS is not going to be able to deliver perhaps all of the care that we want to do so for all of these people going forwards. So what do? How do we prioritise? How do we strategize what we're going to do going forwards? Well, across the world, various different organizations and approaches to this have come up. In where's that one from? Slow medicine. In Italy. In Italy, they've got slow medicine, they call it. In Scotland, realistic medicine. And back in 2014 in Wales, you'll remember the idea of prudent healthcare. Well, prudent healthcare really now has been built upon to come to this strategy of value-based healthcare. What does that mean? Well, this is the definition from the University of Oxford. Value-based healthcare is the equitable, sustainable, and transparent use of the available resources to achieve better outcomes and experiences for every person. So this is about focusing on the person living with type 2 diabetes, thinking about what is most important to that person, but also thinking about which interventions give that highest value. So the lowest cost for the highest value outcome, for the best outcome for the person living with this or indeed any long-term condition. It's challenging because it means perhaps we can't do everything that we want to do going forwards, and we need to prioritise that value-based approach. So thinking about the interventions that have the biggest impact at the lowest cost for the system. And type 2 diabetes lends itself very well to the value-based healthcare lens because it is a journey through type 2 diabetes. From prevention, which of course is the ideal, that upstream management. If we think about value, the greatest value is the left-hand side of this pathway, preventing type 2 diabetes. If we can't prevent it, pick it up early with an early, accurate diagnosis. Once we've got that diagnosis, where's the best value? It's with optimizing intervention, getting that early glycemic control to reduce the risk of the complications later on. Because the biggest spending in type 2 diabetes is on the complications. It's on dialysis, it's on amputation. We want to prevent those occurring in the first place with good optimization and supportive treatment. And of course, we also need to think about end-of-life care, that true journey of type 2 diabetes, the full pathway across a person's life. So I've got a few examples before I finish to share with you about the value-based healthcare approach to diabetes care in Wales. Well, one thing that really informs us around the value of healthcare that we're able to give is data. We have to have good data in order to see what's happening, to think about where those valuable interventions would best be placed. We have the National Diabetes Audit, which is a huge annual audit which collects a lot of data from primary care, such as that essential care process data that I shared with you earlier. The trouble is, it's often 12 or 18 months out of date. So I've recently developed a new Audit Plus module. This is simply a way to access live data at a practice level, day by day, so practice can see how they're getting on with their diabetes care. We can also see at a cluster or health board level how practices are delivering that care, how people are getting on. We can identify areas of need and think about the support or interventions that need to be given there. That rolling live data gives meaning to progress. We know that technology is definitely valuable. We know there's a huge move towards the use of technology in diabetes, including for people living with type 2 diabetes going forwards. The implementation of things like health technology, Wales guidance around things like continuous glucose monitoring, we know this is valuable going forward, but with initial cost. So sometimes we have to think about the balance between initial cost, that invest to save type approach, in order to spend to save in the future. Because we know that the use of technology, again, is associated with a reduction in complications many years down the line, because it can help people to achieve glucose control. We're in the early stages of this. There are successes, but there are also barriers when we're trying to put something new, especially with an initial outspend. But keeping that value-based healthcare lens in our eye is really important, remembering the long-term gains about such interventions. And more locally, here in Cardiff and Vale, we've got value-based healthcare funding for a community diabetes hub, which we're just about to get off the ground. We know that investing in the community, keeping people closer to home, definitely brings value. No need for most people living with type 2 diabetes to go off to that big shiny building, try and park somewhere, see a consultant who are valuable themselves and perhaps should be focusing on other areas of diabetes care. The idea of our community hub is keeping people in the community, closer to home, focusing on education, self-management, that value on the left-hand side of the pathway that I showed you earlier. So this community diabetes hub will consist of that multidisciplinary team that I mentioned, a GP with a special interest in diabetes, community diabetes specialist nurses, dietitians, podiatrists, and indeed a community consultant to try to optimize the care of people living with type 2 diabetes in the community, with a real focus on reducing unwanted variation in care. We know that there is variation in care for people living with type 2 diabetes. We can see it from the data that I mentioned earlier. In areas of deprivation, people living with type 2 diabetes have worse outcomes. And a big focus of our Community Diabetes Hub with that value lens is to focus on reducing inequality. This is just getting off the ground. There'll be lots of outcome measures to come, and I look forward perhaps to coming back and telling you how we're doing. So I'm going to stop talking. I'm most happy to have some questions if we've got a few minutes. We know that the numbers are not great. The numbers of people living with type 2 diabetes are rising in Wales. We must focus on that early identification, education and self-management, and that early optimisation of control in primary care to reduce long-term expensive complications that come at cost of quality and quantity of life to people living with this condition. In primary care, the completion of the essential care processes is a vital part of our everyday work. It's not amazing, there is work to be done, and we're looking at ways to focus on that once more, particularly improving perhaps certain essential care processes, such as getting that urine test done to check on kidney health. The multidisciplinary team is vital to holistic diabetes care, especially in the primary care setting. And the value-based healthcare approach focuses on those high-value, person-centred interventions to improve care. For me, to improve the care of people living with type 2 diabetes in Wales, we need to be holistic, we need to be value-based, and of course, keep the person living with diabetes at the centre of what we are doing. Thank you very much, and I welcome your questions.